Yep. So I have 5 jobs. I run 4 different departments. But I think the one that is relevant here is I serve as a National EMS Medical Director for Singapore. And we're going to talk about the problem of out-of-hospital cardiac arrest. So you guys, let me just have a show of hands. How many of you work in the ICUs? Okay, most of you. Any work in the emergency departments? Okay, a few hands. Any have involvement with the pre-hospital services? Okay, so most of you are at the receiving end, okay? But as you know, a lot of what determines the outcomes actually occurs before they get to you, all right? And this is a concept that we have sort of been working on the last 2 years that we call the modified frame of survival. All of us know the chain of survival, right, that you learn at BCLS and ACLS. But when you take a systems kind of approach, to cardiac arrest, right, then, I would say that, it takes a system to save a life, right? It is not the individual clinician, it is not the individual factors like the previous speaker demonstrated very nicely. It is the chain of events, how they are linked together, and whether you have the system that would actually give the patient a chance to survive. So if you think of the domains, there's the community, there's dispatch, which is the call center, there's the ambulance service, and then there's the hospital, right? And each of your, things that we try to do actually comes into one of these spheres. So for example, if you don't recognize a cardiac arrest, you don't nobody starts bystander CPR, patients has very low chance of survival. If you don't know the right number to call, if they don't give telephone instructions on starting CPR, if the ambulance crews are not well trained, then it goes on and on. And then as EMS National Director, then I have what we call the inner frame of survival, where there are factors within my control, including public bystander CPR training, my protocols, the dispatch training that we have, But there are also things that are outside my control, my sphere of influence, which is what we call the outer frame of survival. So this is where we have to lobby politicians, look at regulations and laws, look at public attitudes, towards, for example, giving the kiss of life, right? And what we do is we actually do a workshop in which we teach people how to look at a systems view of things and actually put in place the entire chain of survival. So I could talk one whole day on this, but let the patient speak for herself.
Hi, my name is Samantha, and I'm a survivor of cardiac arrest. My episode happened in January of 2011. I was getting ready for work when I had a cardiac arrest. When I collapsed, my husband administered CPR on me and called 995 for an ambulance. And when the paramedics arrived, they were able to restart my heart with an AED. And today I'm leading a normal life, and I highly encourage everyone to learn CPR and how to operate an AED, because this would definitely save lives.
So Samantha was only 22 years old when she came to us. Only later we found out very strong family history of sudden cardiac death. The brother died at age 30. And to put a long story short, she would not have survived 10 years ago, right? But we had a whole chain of events starting from the husband giving bystander CPR, from telephone instructions to the, she was in and out of VF 31 times, 31 shocks. Came to the hospital, therapeutic hypothermia, walked out alive, right? And we know that because we have been collecting data since 2001. So one of the early wins that we had was we started a national out-of-hospital cardiac arrest registry. And that has evolved over the years. You can see that in Singapore, we have accumulated probably more than 15,000 cases, and it's now expanded to the Pan-Asian Resuscitation Outcome Study, where we have more than 200,000 patients recruited into the registry. So we know what is going on, we have data, we know what works, we know what doesn't work. And I always say that quality starts with data. No data, no quality, right? I can tell you that we have more than 2,000 arrests every year in Singapore, and 65% of them are actually in the prime of their life, age 40 to about 70, good pre-morbid. More than half of them have no previous history of heart disease. And I can tell you that our incidence of sudden cardiac death or out-of-hospital cardiac arrest is still increasing. And there's various reasons behind that. So one, aging population, but also our diet, our lifestyle has changed dramatically over the last 20 years. So hypertension, diabetes, heart disease are still on the rise in Asia. in contrast with the US or Europe where it's plateaued. And I was talking about, the concept of the chain of survival, that why is it that in one country, in one system, in one city, you can have very high survival rates, and in another system, very low survival rates. The patients are the same. The physiology is the same, right? It is almost certainly due to timeliness and quality of treatment. It is differences in the system, and that can be changed, that can be improved. So about 10 years ago, I actually started working on a concept paper that I pitched to the government about improving pre-hospital care in Singapore. And we looked at the chain of survival as our frame and looked at where our gaps were. For example, poor public recognition, low bystander CPR rates. Our dispatch was, where's your address? I'm going to send an ambulance, right? And then the ambulance crews, were not enough in numbers and training. And then we came up with a 5-year plan, how to address some of these. So what I'm going to show you are some of the results of this over the last 10 years. So we started looking at our data, right? So, and one of the issues was, how many in our population know CPR, have been trained, know how to use an AED, right? And so for the first time, we now have national data that can tell us what that is. And how do we do that? One word, census. So, every 10 years in Singapore, the government does a public census, right? Population framework. Then they go knock on doors, ask you what's your household income, what's your education status, and all that. I managed to sneak in 5 questions. Have you ever been taught CPR? Do you know how to use an AED? And if somebody collapses, would you do something, right? So we have detailed data now. I can tell you that maybe about 10% of my population have been trained, have a valid sort of like first aid or CPR training. About less than half of them of that have a valid AED training. And maybe about 30% will say that I've ever attended CPR class once in my life before, right? But if you ask them, should you learn CPR? 90% will say yes. So there's a gap between attitude, knowledge, and the actual practice. And that's something that, again, we can intervene. The other thing we did was invested a lot in dispatch. So Benjamin, who you heard, is actually my medical director, EMS medical director for dispatch. And he has done a great job, actually implementing our telephone CPR protocol. We have a fire-based EMS system. And basically, we have firefighters that answer the phone. We've now put nurses inside the dispatch center.
995 here.
And then they give instructions.
Okay, you have your father now?
Arrest.
Hello, ma'am. How's your father now? Is he breathing at the moment?
No.
Okay, anybody doing CPR? Ma'am, anybody doing CPR at the moment?
No.
Okay, I teach you CPR, okay? Okay. You put your speaker on loud phone now. Okay, speaker on loud phone now.
It's actual recording.
Okay, ma'am. You take is your shirt open or the father?
What?
Okay, your hand, one hand.
Yeah.
Okay, in between the chest, in the middle of the chest, in between the nipples. Okay, the other hand on top of the first hand. Okay, you press the hand now. You press the chest. I count with you, okay? Okay, 1, 2, 3, 4, 5. Okay?
So this goes on for several minutes, but there's a few very important learning points here. Number one, you can instruct someone over the telephone to start CPR, right? And that person may never have done a CPR class in their life, but they can do it, okay? Number two, it is not an easy job. The dispatcher has to overcome all sorts of barriers because you're only using audio cues, you have no visual cues at all, right? So they need special training, special protocol. And the third thing, you realize Singaporeans like to say, okay. All right, so this is our data. We started our protocol in 2000, okay? And initially, we found that no difference, no improvement in our bystander CPR rates. And I think the key was we were not doing comprehensive quality improvement. So we actually put in place where we'll record every single cardiac arrest call. We play that back, and a medical director like Benjamin or one of my nurses will listen to it. We will give individualized feedback to each dispatcher. And then they will actually, get feedback, get a pat on the back if they did well, or some pointers if they didn't do well. What has been the impact? You can see that our bystander CPR rate have gone from 20% to well over 50% in the space of 3 years. 3 years. And a lot of that is driven by dispatcher CPR. Okay, the other group is you find that even bystander CPR has increased, meaning that a lot of times the person may be a trained responder, but they're not sure, is the person really in cardiac arrest? And by asking them, is the patient conscious? Are they breathing normally? I want you to start CPR now. They will actually start, whereas previously they would have hesitated. we link that with a public education program that we call the DARE program, Dispatch Assisted First Responder Education. And this basically is a 45-minute course that we do in the community, free of charge. And it just tells you 3 things, you know. Call 995, which is our number, put your hands on the chest, press the buttons on the AED. And don't worry if you can't remember all the steps for BCLS. You know, my dispatcher will coach you over the phone. You know, if you can't remember the rate, the depth, we will count with you, no problem. Okay, no test, no pressure, no certificate, right? Make it fun, make it something that is enjoyable.
Today we're going to learn all about cardiopulmonary resuscitation. Everyone can do it if you dare.
Call 995. Stay on the line.
A medical dispatcher will instruct you. Start CPR. Interlock your hands and push.
Push hard and push fast.
Get an AED. Continue to push hard and fast while you wait for the ambulance to arrive. So I suppose you're tougher and more daring now. Goodbye.
And then notice that we put a lot of emphasis on the psychology behind it. You know, so Asians, we are very shy, right? You know, before you eat, you say, father eat, mother eat, grandfather eat, grandmother eat, then you eat, right? You know, same thing happens in a cardiac arrest, you know. Anyone know CPR? No, after you, sir, after you. You know, no, nobody wants to do, right? So then the messaging is, dare to save a life, dare to start CPR, you know, you can make a difference, right? So the psychology of that is very important in the communication. And we have a national strategy that we call the Pyramid of First Responders. So at the base, this is my population, 5.6 million Singaporeans, right? And what I want to achieve is awareness. So you may never have stepped into a hospital, never done a CPR class, but you've seen our TV commercials, you've seen the ads on the bus stop, you've seen our newspaper ads. If I start to give you instructions over the telephone, I want you to kneel down by the side of your patient, put your hands in the center of the chest. They have seen that before. They have a mental picture of what it means, and then I can give you instructions. Then there's the base of the pyramid. This is 1 million people we are aiming, 1 out of every 5 in the population that we have gone through our 45-minute course in schools, in churches, in mosques, in community centers, you know, in your workplace. No certificate, but you know, they would have hands-on practice, and more than 50% of the time would be hands-on practice. So they would have learned some of the mechanical skills that are needed. And then we tell them, if you have interest in this, move on to a certified course. So this is your standard 3-hour CPR plus AED, BCLS, you know. So move them to a certified course where you learn the proper skills, you learn how to do choking, infant, you know, drowning, and all the other things. And then move some of them up to become instructors, and they can teach the rest, you know. So this is our sort of like strategy we've been implementing the last few years. I like this picture. This is my boss, the Minister of Health. This is my pastor. We're in the church hall. There are 500 people there. They're all learning CPR together after the church service. And what you don't see is next to him is the leader of the mosque across the road, the Buddhist monk, the political leader, the grassroots sort of like community leaders, and they're all learning CPR together. And after that, the imam of the mosque came up to me and said, hey, oh, church very good, huh? Next Friday, come to my mosque and we do the same thing. Okay? Every year we have something that we call Survivor Award Singapore. So this lady had a cardiac arrest. The husband made the phone call. The daughter actually took instructions over the phone and started CPR. And then we have a ceremony where the survivor will come, give an award. And the award is not for the survivor. They survived. That's their reward, right? But the award is the bystander who came and did something, the person who took telephone instructions, the dispatcher who gave instructions over the phone, lots of tears, hugs, cameras, and then we get our message across, say, learn CPR, save a life, right?
You can still save a person's life even if you have not been taught how to do mouth-to-mouth resuscitation. That's according to a recent study by the Singapore General Hospital and the National Heart Centre, Singapore. So SGH is now planning to expand the pool of people willing to respond to emergencies with an easy-to-learn CPR training program. Sarah Gross reports.
These Singaporeans are being trained to do chest compression. They also learn to follow a medical expert's instructions in performing CPR and to use an automated external defibrillator.
So I'm going to cut short because of time. My 30-minute talk became 20 minutes, right? The other thing that we have done in the last 2 years is link our responders with the patients through an app. So we call this the My Responder app. So if you go to your Google Play Store, Apple Store, you type My Responder, you'll find this app that you can download for free, and it has 3 functions. Number 1, It will auto dial if you click on the button 995 and put you on speakerphone, and it will send your GPS location to the dispatcher. This was a problem in the past, you know. Where are you? I'm in Bishan Park. Which part of Bishan Park? Under the coconut tree, you know. Which coconut tree? The one with the coconut lah, you know. And then my ambulance goes round and round, can't find you. Right now, I can tell you ambulance is on the way. 5 minutes form. It's like Uber, right? Number two, if there is a volunteer first responder within 400 meters of a cardiac arrest, we will activate you. And I now have 30,000 volunteers on the system. So every CPR class that we teach in Singapore, the last slide I mandate, because I'm National EMS Medical Director, last slide you must show is my Responder app. Download this app now that you have learned CPR. Okay? And in the last 2 years, we've had 15,000 responses. In about half the time, we are there before the ambulance. About half the time, we have first hands on chest, and about 5% of the time, we are putting on an AED. And I have dozens and dozens of saves that we have documented, you know, and hopefully some of that data will start coming out in the publication soon. And then the third part of it is it's linked to our national AED registry. So we have a national AED database. We have people who go there and inspect the AEDs, update that information. So if you get a ping, it's like Mission Impossible, right? Ethan Hunt, are you willing to respond, right? Then you say yes. It will show you where's the victim, where's the nearest AED. Hopefully, the person who made the call is starting bystander CPR, telephone CPR. Second responder will go and grab the AED and then save the patient.
本地每天平均发生的5到6起心脏骤停个案当中，就有1起通过 My Responder 应用程序获得附近路人的及时协助。
而让用户反馈社区问题的一联通应用程序，至今接获了5万多个反馈。
科技姓名系列报道，记者蓝丽婷带大家了解政府科技局与各部门合作推出的应用程序如何走入民众生活。
接获民众995电话，发现有人心脏骤停。派出了急救人员后，民防人员还会通过电话指示在场民众如何施予心肺复苏术，同时也会启动 My Responder 应用程序，让附近用户立即获知有人需要急救，并赶往现场协助。应用程序每个月平均会启动400次，目前已有超过11000多名登记用户，大多懂得心肺复苏术，但一些人仍对施救有所迟疑。
So I'm going to just show you, again, because of time, you know, the number of alerts has been increasing. Our response rate is about 30–40%. And very, very nice. The AED is also linked to a national program where we are putting AEDs at the bottom of public apartments. So, you know, 90% of my population lives in public housing, high 30-floor, 40-floor, 50-floor apartment buildings. And we managed to get AEDs basically installed in the basement of, or the ground floor of all this next to the elevator. Right, you ask me, how do we find the money? 2 words for you, gambling taxes. Okay, so we went to the National Lottery Board, you know, say, this is the idea, oh great, you know, so after this, go and support our AED program, you know, the casino is just across the road, right? And because we have an app, we now can look at innovative models of how to deploy the AEDs. So we have a pilot where we have trained basically 150 taxi drivers. And there are 100 taxis that are going around there with AEDs on board, right? So if you're on foot 400 meters, if the taxi is within 2 kilometers, we'll dispatch a taxi with an AED to you. So again, because of time, I'm going to cut it short. Right? Okay, we've also looked at innovative tools to improve the quality of CPR. So I've been working the last 5 years with the Liddell Corporation on what we call the CPR card. So this is a credit card size device. All right, it's got an accelerometer on it. And we have 15,000 of these in volunteer community responders. You put it on the chest, you start doing your CPR, it will actually show you the rate and depth of your compressions. And it's got a memory chip. So after that, we actually can download data. And I actually have the first peek in the world to see what volunteer first responders are actually doing in the field. What kind of rate, what kind of depth, what kind of pauses they are doing. And we're using that to feedback to them on how to do a better job as first responders. Okay, so I'm going to breeze through the last few, you know, so not forgetting the ambulance system, you know, we have looked at things like putting motorcycles with AEDs and they can zoom through the traffic, cut down in half the response time. That's worked pretty well for us. We've looked at using computer simulation models to tell us where to place our ambulances, how many ambulances we need, strategic planning. we have a tiered response where the first guy that we send out is this motorcycle. The second is going to be a fast response fire vehicle with 4 firefighters to do high performance CPR. And then after the ambulance. Okay, of course, these are for disaster and all that. We look at high performance CPR, where the team are trained like a ballet, they are orchestrated and they work with mechanical devices. We use a pit crew kind of model. We have some basic drugs that we carry. We are not a full-scale advanced life support system, but these are the things that we think make a difference, good value for money. We've brought in intraosseous. We have put in a national therapeutic hypothermia program that Ben has talked about. What has been the impact of all this? I can tell you when I started collecting data, 2001, our survival rate was 2.5%. 2.5%. By 2011, we are at 11%. 2015, 21. My unofficial 2016 data is about 23, 24%. 10-fold increase in survival. I have basically now 150 more survivors than every year than what we had 10 years ago. There's not many things in medicine we can claim a 10-fold increase in survival. For all the millions, billions we've invested in genomics research, cancer research, fancy pumps, fancy drugs, fancy surgery, I can show you that by looking at a system approach, we can increase survival by 10-fold. And that has come with sort of like a step wedge of different kind of interventions that we bundled together. And we know it works. We are still working on the next round of interventions, training my paramedics to do manual defibrillation, bring in amiodarone, and we are working as a network with the other Pan-Asian countries. The trial that we are concluding at the moment is a randomized trial on dispatcher-assisted CPR across Asia. So this is my last slide, that it has to all come together. Data, research, translation to practice, policy, even regulations and laws. But we can make a difference and we can impact care. Thank you very much.